Thanks, Dr. Raja. After such an excellent presentation by Dr. Anawat, I'm going to make an effort to talk to you on arthrofibrosis, which is one of the complications which can occur after a knee replacement. So, how do you go to next? Next. Huh? Okay. So, arthrofibrosis is not a very well-defined entity. It is a condition which results in functional impairment and restriction of knee motion following a knee surgery or post-surgery or post-injury. After a trauma, one can get arthrofibrosis. The incidence of arthrofibrosis following total knee replacement is less than 2%. And to define a stiff knee, any knee with movement less than 75 degrees is considered to be a stiff knee. And at this point of time, I would like to clarify that all stiff knees are not arthrofibrotic. There is definitely a clear difference between arthrofibrosis and a stiff knee. And Dr. Thomas is going to talk to you more about stiff knee in his next talk. The various causes of stiff knee could be pre-operative. If the patient is previously operated a couple of times and he comes for TK, underlying diagnosis, patients with ankylosing whom you do a takedown and do a knee replacement will not get optimal knee ROM. And various intraoperative surgical errors, Dr. Ranawat just talked about them. Various surgical intraoperative errors, technical errors like inaccurate ligament balancing, oversized components, elevating the joint line which leads to patella infera. And all these things can lead to a reduced ROM and something like an arthrofibrosis. It is also important to find out which are the various other post-operative conditions which can lead to stiffness, because arthrofibrosis is a diagnosis more of elimination. You can't really diagnose arthrofibrosis. You've got to find out whether the patient has RSD, a complex regional pain syndrome, deep infection, heterotopic ossification, and once you've ruled this out, probably you can make a diagnosis of arthrofibrosis. We've had a full session on deep infection and we can pick that up. Heterotopic ossification is not very common, and significant heterotopic ossification which can limit ROM is, the incidence is less than 2%, so not very common. Important thing is to identify the complex regional pain syndrome like the RSD-like syndrome, and it is an exaggerated sympathetic response. Along with pain and reduced motion, which is seen also in arthrofibrosis, in RSD you will see vasomotor disturbances like hyperesthesia or excessive sweating, which will not be seen in arthrofibrosis. Also, there may be periarticular osteoporosis may be present. And once you've made a diagnosis of a RSD, a lumbar sympathetic block can be diagnostic, and if it is working, it can be therapeutic as well. And one can consider to give lumbar sympathectomy surgery to that patient in cases of RSD. What happens in arthrofibrosis is that there is periarticular fibrosis which limits range of motion by forming bands of scar tissue between quadriceps mechanicus and distal femur. What triggers this proliferation is still not clearly understood. It's probably postulated to be a T-cell mediated response or an overexpression of the TGF-beta, which is one of the factors released by the platelets required in tissue repair. So there is overexpression of that. Histopathologically, the scar tissue shows ovoid and spindle-shaped cells with characteristic of fibrocartilage, and there is a predominance of type 6 collagen in the histopathology. There are various predisposing factors. If the patient has a keloid tendency, he may be predisposed to arthrofibrosis. There has been an association shown between the HLA-CW08 antigen and the presence of arthrofibrosis. Poor pain tolerance and patients with, who are not very compliant with physiotherapy, type B type of personalities probably can develop this. The effects are that once the arthrofibrosis develops, the medial and the lateral gutters, they get obliterated, and this leads to the reduced range of motion and also the patellofemoral mobility. Clinically, this presents as pain, stiffness. Patient may have some warmth, swelling, which can mimic something like an infection. Patient has an antalgic gait and may walk with a flexed knee. It is important to, at this point of time, to rule out other causes, and an X-ray can be helpful to find out the position of the implants, whether the slope is too anterior. Also, a CT scan is helpful if one is suspecting a femoral component rotation, and that is one of the important causes, especially the internal rotation of femoral component. Dr. Anna just said that can lead to post-operative problems and reduced movements. Once you've made the diagnosis of arthrofibrosis, there are various options you have in front of you, right from aggressive rehab to revision surgery. in the initial first 3 to 4 weeks, we have to counsel the patient, put the patient on vigorous physiotherapy, dynamic splinting. CPM at this point of time can definitely help, but at this time it is important to understand that the patient has to have adequate pain control, and if patient doesn't have good pain control, he's not going to really respond to your rehab. So that is one of the important things. Manipulation can be considered if your rehab is not helping, and it can be done. It is important to have complete muscle relaxation, and we should not be too vigorous with it because it can cause periprosthetic fractures or extensor mechanism disruption, patellar tendon disruption have been reported. When I was a fellow at the ROC, there was a study which they did with manipulations and with and without the use of Ranawat cocktail, and the gain was significantly more in patients who received the cocktail along with the manipulation. And this wasn't necessarily for the arthrofibrotic patients, but generally patients with reduced ROM post-operatively. Arthrolysis is something which can be considered if the patient is not responding to manipulation, excessive rehab, and then you have to think of arthrolysis, which can be done arthroscopically or open. Arthroscopic is of course less invasive, but at times you may not really be able to see well, you may not be able to maneuver your scope in presence of a joint, and the reflection can be really very hazardous to give you a good view. So open arthrolysis can be considered where you do a radical debridement, complete medial and lateral gutter release, quadriceps plasty, pie crusting may be done, an exchange of poly can be done to a thinner size, and this can help. Revision should be considered only if you can identify a technical error, and it has been shown that the internal rotation of the femoral component has a strong association with arthrofibrosis, especially when there is repetitive microtrauma leading to chronic inflammation and arthrofibrosis. And in these conditions, no matter what physiotherapy you give, manipulation you give, if the femoral component is internally rotated, one has to think of a revision, and nothing less than that can probably help. The principles of revisions remain the same: wide exposure, you may do a quadriceps snip if required, or a tibiotubercle osteotomy, excision of the scar, maintain the alignment, and now this time the components have to be really put in the proper alignment, maintaining the joint line and good post-op pain control. Thus, in summary, once you have a patient with reduced ROM after TKR, do a proper clinical evaluation, investigate him. If you can find any technical errors, you can deal with that. You have to rule out infection, RSD or heterotopic ossification to a diagnosis of arthrofibrosis, and I've just told you the algorithm: up to 3 weeks rehab, 3 to 6 weeks manipulation, and more than 6 weeks if still don't get ROM, then can consider arthrolysis. So arthrofibrosis is a frustrating complication. Prevent it if you can. Think of all the differential diagnoses before labeling it arthrofibrosis. Consider revision only if you can find an identifiable cause and which can be surgically treated. And further research is required whether if you can preoperatively find a patient who has a HLA-OW8 positive and who's going to probably develop arthrofibrosis. We don't know how to also control the T-cell mediated response, and if in the future we can control that, probably we can prevent arthrofibrosis. Thank you very much for your attention.